Great, so we're recording. So today is the 23rd of October, 2020. And thank you, Dr. Ros Adlard, one of our registrars, for agreeing to talk about a paper from the European Child and Adolescent Psychiatry Journal on a systematic review for psychological interventions in psychosis. And I think that's a really interesting and important topic for us to talk about. So Ros, I will hand over to you and let us know if you want any participation during the presentation, or otherwise we will certainly try to make sure we have time for questions afterwards. Thanks.
Right, thank you. Thanks very much, Prof. Hi, everyone. So, yes, so as Prof has said, I'm going to be discussing this paper. It's a systematic review on psychological interventions in psychosis, and specifically looking at psychosis in adolescent age group, which I thought was interesting. It's a fairly recent review article, so hopefully fairly relevant, and will give us a fairly updated idea of what's going on in this field. And look, it's just putting it out there, I'm not a psychologist, and this isn't an area I know a huge amount about. So it's really for my own learning that I'm doing this, but I would love for the psychologists here joining us today on the team to please jump in and feel free to share your thoughts about what I'm going to be talking about. I really hope to hear from some of you about your experiences and about your thoughts about this paper. Okay, so just by way of introduction, the paper starts out talking about early onset psychosis, which here they define as psychosis with an onset before the age of 18. They said this tends to be quite a severe form of psychosis with a worse prognosis than other forms, than psychosis that tends to start at a bit of a later age. It's associated with generally with poor outcomes and also with medical comorbidities. And it can occur in a range of different disorders, for instance, a schizophreniform, a schizophrenia, bipolar disorder, etc. Symptoms involved can be, as I'm sure we all kind of are aware of, but just to go through quickly, so sort of positive symptoms, for instance, unusual beliefs, delusions, or perceptions that are so strange perceptual disturbances. There can be negative symptoms, for instance, blunted affect and a lack of motivation. You might have disorganized symptoms, for instance, disorganized thinking, and also group here concentration and memory problems. And then there can be affective symptoms, for instance, high and low mood and or mood dysregulation. So psychosis tends to also be associated with cognitive deficits. There are very high personal costs involved with psychosis, as well as broader societal costs that result from psychosis. In terms of general psychosis, they talk about schizophrenia-like psychosis. Adolescent onset cases account for less than 15% of all cases of schizophrenia-like psychosis, and the highest incidence of psychosis is in late adolescence and early adulthood. So in terms of current treatment guidelines, and here I checked the references, and I think they're referring specifically to the NICE and the WHO recommendations. They recommend CBT for psychosis, as well as family-based interventions in patients with psychosis. Wider psychosocial care plans are often recommended as well. It's generally recommended that patients over 16 should be in specialized psychosis services, and that intensive support in the first 2 years is provided by early intervention psychosis services. They say this initial 2 years is quite a critical period in terms of future outcomes. So getting involved here can make quite a significant difference. So previous studies that have been done have looked at psychological interventions plus medical treatment, which seem to have a more favorable outcome than treatment alone. So studies comparing these two groups have shown a favorable outcome where psychological services are essentially included on top of medication. However, there were no previous systematic reviews looking at only early onset psychosis patients. So the aim of this review was to assess the evidence on efficacy of psychological treatment with respect to positive and negative symptom reduction, cognitive functioning, and also psychosocial functioning. So in terms of the methods that they used, they followed the PRISMA guidelines throughout the review. They did a search of, electronic database search of PsycInfo, Medline, and Embase, which were searched on the 19th of January, 2018. Keywords, I'm not going to read through all of those, but you can see there what all the keywords were that were used. They used both English and American spellings. They then went through all the papers that were identified and also hand searched through the references. Initially, abstracts were screened of the papers that were identified, and then the actual papers were read, and it was decided which ones to include in the study. Eligibility criteria were that they only included randomized controlled trials. They wanted studies with participants between the ages of 12 and 18. They looked at specifically at papers where the diagnosis of psychosis was made as per either the ICD or the DSM, depending on, you know, what was used in that particular study. However, they did say that they did include some examples of where there were both diagnosed patients as well as at-risk patients that were included in the study. They did sometimes look at some follow-up studies, but these were only included if the original study was also included, and this was to give further information about longer-term effects of the interventions. They excluded any papers that were not in English. They excluded symposium abstracts, poster abstracts, dissertations, and all papers which included adults in which they couldn't extract the specific adolescent data. Outcome measures that were looked at included symptom reduction, amelioration of cognitive function, changes in psychosocial functioning, and they said that they assessed bias in all papers using the JADAD scale for randomized controlled trials. So in terms of the results, they started off with the initial 129 papers identified. This was condensed down then after exclusions to 8 papers that were included in the study. So not a huge amount. So they said in these papers, a variety of different interventions had been looked at, had been studied. There were some certain papers looking at cognitive remediation therapy, CRT. 2 studies looked at CRT, as well as one follow-up study. Then there were some studies looking at computer-assisted cognitive remediation, this is CACR. In here, looking at this was one study as well as then a follow-up study. One study and a follow-up looked at a psychoeducational approach, and then another study looked at a combination of CBT plus a family intervention. So the outcomes that were studied, the outcomes that were specifically looked at in these papers depended on the different treatments used and on the study. In the CRT studies, they tended to look at improvement in cognitive deficits, whereas in the CBT, family therapy, and psychoeducation studies, psychosocial functioning was what was considered. Okay, in terms of the results, to group broadly into the different outcomes that were looked at. In terms of psychotic symptoms, these didn't seem to be significantly affected by the study. They go into a bit more detail in the paper, you can have a look at, but the bottom line is they really didn't seem to be affected. In terms of psychosocial functioning, there were mixed results in this group. There was, so there was one CBT study, one family therapy, and a CRT study, which did show significant improvements in psychosocial functioning. However, one of the other CRT studies didn't show significant improvement. And then one of the CACR studies showed significant improvement in both the experimental and the control group. In terms of cognitive functioning, this was only explored in the CRT studies, really. And all of these showed improvements in different areas of cognitive functioning. So one study showed improvement in visuospatial ability, which was retained in follow-up. And And in addition to the follow-up, they found improvements in executive functioning and reasoning. Another study showed improvements in executive functioning as well as verbal and working memory. And one of the other studies showed executive functioning, attention, and memory that were improved. This was retained follow-up as well as improvement in early visual information processing. However, they do note that in this study, the control group also showed improvements over time. Okay, so in terms of the discussion, there have been a number of psychological interventions that have been proposed as a complement to standard care of psychosis. Standard care, I presume, being sort of the more medical model of care. This is the first review that has evaluated the effectiveness of these interventions in adolescent samples. Cognitive functioning seems to be the area, as you can see from what I've said in the results and so on, that has received the most attention in this review. And there is some evidence for CRT specifically to improve cognitive deficits. There's also some benefit, or some evidence for benefit on psychosocial function. There's no significant effect, it seems, on psychotic symptoms specifically. It does appear, they say, that psychoeducation appears to aid in relapse prevention. However, this was only explored in one study, so a bit limited in terms of the data that was obtained there. Okay, so looking a bit now at adult studies, there is a view that treatments need to focus on the achievement of various sort of life goals, individual goals that the patient has, and as well as improving quality of life, as well as targeting psychotic symptoms. And there is a focus in adult work on developing psychological treatments that target the underlying processes that maintain distress and impairment in these patients. It has been suggested, again, I think from adult work, that psychosis can be treated by applying normal psychological processes. And they say this is based on the view that psychological mechanisms are thought to be similar between various unusual experiences and psychotic symptoms. So because of sort of common mechanism, it's thought that you can use normal psychological processes in psychosis as well. One of the CBT treatment studies that focused on, sorry, not in this review, but another CBT treatment study that focused on achieving personal goals did show improved self-esteem as well as improved psychosocial functioning. And the thought is that CBT could similarly aim to reduce distress and disability by promoting flexibility in appraisals of personal experiences. So this review's findings are in keeping with this, in that most studies showed some improvements in psychosocial function as opposed to actual symptoms. And they say that the development of effective psychosocial treatments targeting psychosocial functioning should become, or should possibly be, a separate focus of attention in this group. The findings the findings from this study in terms of CRT decreasing cognitive symptoms do correlate with findings in adult literature, and it's proposed that memory and executive functioning are areas that benefit the most from CRT in schizophrenia. So all of the included CRT studies in this review have shown similar results. Adult studies do seem to suggest that if the cognitive deficits improve, social functioning improves in turn. However, this is less clear in the adolescent group. And this relationship between cognitive deficits improvements and psychosocial functioning in the specific group of early onset psychosis does need more exploration. So the CRT, which is, as you would have seen, was used here in most of the studies included in this review, specifically does target cognitive deficits. And it is possibly why this is the area that shows the most benefit. There was only one pilot study included on CBT, so it's a bit difficult to evaluate the role of CBT in this group very well. But adult studies of CBT do show that CBT can significantly improve both negative and positive symptoms. It also accelerates remission. It's been shown to decrease remission from an average of 6 weeks to an average of 4 weeks in adults. And it seems to be very efficacious, or to have some efficacy in the treatment of combined hallucinations. The parallel study on CBT that was included here by Browning et al. Did show some psychosocial functioning improvements, but they do say that more research specifically on CBT in adolescents with psychosis is needed. So they make the point that adolescents may well respond differently to CBT than as compared to adults, that adult interventions may need to be adapted in this age group, and various areas that they suggest may need to be adapted include the language used, the pace and the duration. This is due to differences in sort of adolescent concentration and attention spans. Behavior activation and social skills training can be used for behavior change. They also make the point that in the adolescent group, where you're often using the parents as co-therapists, this is an area that needs to be looked at in terms of developing mutual problem-solving skills and coping strategies. So again, this would differ a little bit from adult CBT. And then, of course, in terms of adolescents who are at school, there would be a need to liaise with the school and possibly involve the school as well in what's going on. So that's another area that it may differentiate, that it may be different from adult CBT. Okay, in terms of the limitations of this particular paper, most studies included focused on CRT only, and so there was fairly limited research into the other options available. They included studies that were used in different psychological treatment. Sorry, the included studies used, as a comparison group, some of them used different psychological treatments as opposed to simply a treatment as normal sort of group, which may confound results, especially regarding the secondary outcomes. There were some of the papers had quite small sample sizes, so they may have mistreatment effects because simply from a lack of statistical significance, treatment effects couldn't be picked up. However, they do make the point that larger scale studies are difficult to conduct due to the fact that these conditions are quite rare and so on. There's a need to take cognitive developmental factors into account when designing psychological interventions, and especially in this age group. The outcome measures such as relapse measures and family burden in this group were not specifically looked at, except for one study that looked at them. These are often outcome measures that are often examined in adult studies, but haven't really been examined in the specific group of early onset psychosis. And in young adults with psychosis, there is evidence that family interventions do reduce relapse rates. So there's a need to explore this further in adolescents. In terms of the insights gained and the strength of the study, it does seem to be fairly clear that CRT is beneficial. However, CBT and family therapy work needs further exploration. So they did include only RCTs, which they say did give a high quality of data, and therefore their results are of fairly high quality. Most of the studies included had high Jared quality scores. All of the scores are, by the way, in a table at the end of this paper, if you'd like to have a look at those. But most of them had quite a high Jared quality score. There is an urgent need for effective psychological interventions to be used alongside medical treatments in order to target residual debilitating symptoms of psychosis. And it does seem to be clear that adding a psychological intervention may well lead to better cognitive functioning and improved psychosocial outcomes. So in conclusion, psychological interventions can play a role in improving cognitive deficits and possibly psychosocial outcomes in patients with early onset psychosis. They do say that there's an urgent need for further research in adolescents, and that evidence-based psychological interventions in adolescents with psychosis may help to reduce the burden and impact of the condition, as well as aiding in recovery. But yes, but further research is needed. So I think that's all from me. Thanks very much. And I don't know if anyone has any comments.
So let me just check before I switch off the recording, Ros. Were you planning to make any kind of critical appraisal comments on the paper? In other words, on the systematic review methodology, or do you have any general comments just to make about that? If you don't have any, if you haven't prepared a systematic critical appraisal?
Sorry, no. So I haven't prepared a systematic appraisal. I was sort of presenting the paper.
So then just put you on the spot for 2 seconds. What did you feel was good and not so good about this paper? I mean, what were you're the one who's obviously read it and studied it in most detail. So did you get what you were looking for, or what did you think stood out as good and as perhaps still problematic?
Well, I mean, okay, so it's on a field I know a lot about, so perhaps I'm not the best place to comment on that, but I think that it gave a fair overview of the work that's been done in this field. I mean, I suppose one obvious sort of issue is that, you know, only 8 studies were included. So then again, there were fairly high quality studies. There were RCTs that were included and seemed to be studies of fairly high quality. However, yeah, so only 8 isn't really a lot to go on. And perhaps one, you know, again, I don't know much about the work that's been done in this field, but perhaps including other studies might have been beneficial in terms of adding to the evidence and being able to make more sort of comments or what's the word, conclusions.
Yeah, I guess if nothing else, it tells us that not a lot of randomized controlled trials have been conducted in adolescents with early onset psychosis. In contrast, in the adult psychosis literature, a lot of work has been done on psychological interventions. So that's an interesting idea. And we can talk, and we'll now go on to think, you know, were there maybe other kinds of intervention studies that could also have told us something. If you only find 8 RCTs, maybe there's value also in broadening it out, as you say, to other kinds of intervention studies or intervention approaches. Great, good. Well, at that point, I'm going to stop our recording and we will open up for discussion. Let me just press the stop button here.